Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm joined in the studio today by my colleagues.
I'm Sangeeta Krishnan.
And I'm Rhiannon Ashman.
So today we're going to dive into the topic of neurology, looking at neurological symptoms and signs, and also thinking about headache, as that's a very common presenting symptom in primary care. Today's discussion will remind you about some of the well-known and less well-known symptoms to look out for, what they could mean, and we'll also keep you up to date with the latest guidance on headache and migraine, with tips on management and the role of the latest treatments. So first of all, let's look at some nice guidance on neurological conditions that came out a while ago. But I think this is still really useful for GPs as it's symptom focused and it contains recommendations about clinical practice along with case studies. Dr. Sonia J wrote a summary of this guidance for MIMS Learning, and we're going to look at some of the symptoms covered in her module and branch off into more discussion about them based on other CPD learning that we have on our site. So what are we starting with, Sangeeta?
So the first symptom that was discussed in the guidance is blackouts. Dr. J reminds us that new onset blackouts with features strongly suggestive of seizure require urgent referral to neurology. However, adults with blackouts and clear features of vasovagal syncope like lightheadedness, dizziness, nausea, pale skin, a sudden warm feeling, a sudden feeling of tiredness, yawning, sweating, or a slow pulse do not need neurology referral as such. Speaking of, we have another module on the diagnosis and management of functional seizures. It has a really useful table on signs and symptoms of epilepsy, syncope, and functional seizures. I'll give two examples from the table. First, a gradual onset is frequent in functional seizures and common in syncope, but rare in epilepsy. Second, ictal incontinence is frequent in epilepsy, but only occasional in syncope or functional seizure. What I really like about this table is that it has lots of other information, and I think it makes a great quick reference guide for use in practice.
Yeah, and we've also got a red flags module on transient loss of consciousness, which covers a whole range of causes of loss of consciousness, some of which are neurological, but other causes might include intracerebral hemorrhage, cardiomyopathy, even hypertension or severe electrolyte imbalance. And this module gives some signposts on referral to cardiology, full services, or neurology. And it also talks about when medication review might be required if there is postural drop or evidence of hypoglycemia. So that's a really useful resource as well if you've got a patient in front of you who reports a transient loss of consciousness.
Great. So returning to our neurology symptom list in Dr. J's module, next up is dizziness and vertigo. Again, these are very common presentations to primary care with a variety of causes. And I looked up the distinction between these two. Dizziness is a sensation of being off balance and maybe one of the symptoms of vertigo. But vertigo is much more than dizziness. It's a feeling that you or your surroundings are moving. If a patient has dizziness without vertigo, there are a multitude of possible causes, including hypotension, anemia, thyroid disease, and hypoglycemia, to name but a few. And Dr. J says that dizziness is unlikely to indicate a serious neurological pathology, but if it's accompanied by a focal neurological deficit, altered gait, or deafness, then more investigation is required. If patients have dizziness with vertigo, benign paroxysmal positional vertigo, or BPPV, may be the cause, and the Hall-Pike manoeuvre can help to identify rotational nystagmus associated with BPPV, and the Epley manoeuvre can be used to manage it.
Can you just remind me what each of those entails, Pat?
Sure. The Hall-Pike manoeuvre is where you ask the patient to turn their head 45 degrees and then lean back with one ear pointing down to the ground while you check for nystagmus. And in the Epley manoeuvre, while the patient's still in the lying down position used in the Hall-Pike manoeuvre, they then turn their head 90 degrees, then rotate their body onto the side their head is facing, and then sit back up with their head still at 45 degrees. And if you want a proper refresher of these, there are lots of videos available online.
Yeah, and there's also another important test for people who have sudden onset acute vestibular syndrome, the HINTS. That's head impulse, nystagmus, and test of skew maneuver. A negative hint makes the diagnosis of stroke very unlikely, but it's important to refer immediately if you do suspect a stroke.
We've only talked about 2 of the presentations covered in the guidance so far, and it's already apparent that finding the cause of some of these patients' problems must be a real challenge. However, that must be part and parcel of GP's work, and I guess that's what all the training's for, to help navigate your way through the diagnostic maze.
Can I talk about facial pain now? I think this is an important symptom to cover as well, because apparently 15% of GP consultations involve the head and neck, which I assume includes headache, but it seems a lot. Also, facial pain can be a challenging consultation given the variety of potential causes, the fact that it might lead to some significant patient distress, and the clinical overlap with general dentistry. Now, that's the opinion of Dr. Rupesh Amin, who goes into quite a lot more detail about facial pain in a red flags module that we've got on MIMS Learning. He provides an acronym to aid diagnosis.
Yeah, so this is the Socrates acronym, where S stands for sight, O for onset, C for character, R for radiation, A for associated factors, T for timing, E for exacerbating or relieving factors, and S for severity score.
That sounds really useful, and perhaps something you could apply to pain in other locations. In the neurological symptoms update, Dr. J reminds GPs that facial pain with persistent numbness, facial weakness, or abnormal eye movement requires an urgent referral to exclude a space-occupying lesion. Trigeminal neuralgia, refractory to treatment in primary care, also requires referral, along with suspected giant cell arteritis. This is rare in those under 50, but if it's suspected, you should make a same-day referral.
What are the characteristics of those conditions, Pat?
Where trigeminal neuralgia is concerned, this is a severe, unilateral, shock-like and paroxysmal facial pain for which the peak incidence is in people aged 50 to 60 years. However, up to 5% of cases of this condition are bilateral, and 5 to 10% of cases can be caused by something other than a compressive blood vessel. So these other causes can be things like multiple sclerosis plaques, acoustic neuroma, arteriovenous malformations, and skull base abnormalities. So when it comes to giant cell arteritis, this causes malaise, visual disturbance, shoulder stiffness, and/or jaw claudication. And finally, don't miss carotid artery dissection, which is another condition that should be treated as an emergency. This can affect a patient with no history of TIA or neurological symptoms. So the presence of headache, facial or neck pain, along with an ipsilateral Horner syndrome, such as a constricted pupil or drooping eyelid, and contralateral stroke should be remembered, says Dr. Amin, in case you come across those 3 things together. So there's some really serious things to look out for there. And another thing that shouldn't be ignored, stroke, is mentioned again in the next section of Dr. J's guideline summary, and this bit is on gait unsteadiness, in other words, unsteadiness in walking.
Thanks, Pat. Yes, so as you've suggested, a sudden onset of unsteady gait might indicate a stroke. A rapidly progressing unsteadiness of gait could indicate a brain tumour, an autoimmune condition, an atypical infection, or even a paraneoplastic presentation of ovarian, lung, or breast cancer. A cerebellar or proprioceptive sensory lesion could also cause gait ataxia.
Yeah, so what I really found fascinating was that in those with gradually progressing unsteady gait, in addition to the usual history taking and tests, GPs should consider testing to eliminate for celiac disease.
Wow, that's interesting. Why is that?
So we looked into it, and the link between cerebellar ataxia and celiac disease has been known for decades. So apparently, undiagnosed celiac disease can lead to something called gluten ataxia. This is an immune-mediated condition, and it involves circulating anti-gliadin antibodies produced in response to gliadin, which is found in wheat.
Oh, very interesting.
So alcohol misuse is also mentioned in the context of cerebellar ataxia, with Dr. J recommending vitamin B12 and folate, TSH and full blood count, and liver function tests for people in this category.
Yeah, because alcohol overuse can block the absorption of B12, and neurological symptoms can be one of the signs of B12 deficiency.
Yeah, and we have a newly published guidance module on vitamin B12, which we'll put a link to in the podcast player.
Going back to stroke for a moment, apparently sudden handwriting difficulty may raise the possibility of a stroke.
That is really interesting. That's not something you hear about often. You hear more about the classic symptoms of stroke, which are things like limb weakness, sudden onset unilateral transient sensory symptoms, and as the first mnemonic reminds us, the key symptoms of stroke are face, arms, speech and time. Patient's face may have dropped on one side, they may have weakness or numbness in one arm, and their speech may be affected. So overall, a wide range of presenting symptoms and their possible causes are covered in this module, and I suspect that neurological symptoms will be something we return to in future podcasts as they're very important. But let's just touch on two more things from this module. Firstly, low back pain, where there's a very important and specific red flag.
Yes, it is. So, if the low back pain is severe and radiates into the leg, and there is new onset bladder, bowel, or sexual dysfunction, or new perineal numbness, Dr. J reminds GPs to immediately refer such cases. This combination of symptoms may point to cauda equina syndrome, where there is compression of the nerves in the cauda equina at the base of the spine.
Thank you. And there's just one more thing that I wanted to pick out. We all know that COVID-19 can cause loss of smell or taste. I found it took 10 months for my sense of smell to come back after I had COVID. But there are serious conditions to consider associated with disturbances of taste and smell.
Yeah, one of these is that temporal lobe epilepsy can be associated with transient or repetitive taste or smell hallucinations. Another one is that if loss of taste or smell goes on for more than 3 months and you've eliminated causes like COVID, like you had, Pat, or degeneration caused by Parkinson's or Alzheimer's, then the patient should be referred to a neurologist. And Dr. J says to be particularly vigilant with younger people and those who have other focal neurological deficits such as headache, memory issues, or personality change, because this might suggest a malignancy such as a frontal lobe tumour or an olfactory groove meningioma.
So that's a useful reminder. So do go and have a look at Dr. J's module, as it has case studies as well as recommendations for audit in your practice. It provides a useful refresher on some really important but quite challenging scenarios where a patient's symptoms can have a lot of potential causes. And it has a great case-based quiz as well. So moving on to headache. Headaches account for 4.4% of primary care consultations, apparently. Are you aware of the latest guidance? What are the red flags you need to consider? And are you up to date on the latest treatment options? So, Sangeeta, can you tell us what the latest guidance is?
I sure can. There are 2 pieces of guidance from NICE and from SIGN, published in December 2021 and March 2023, respectively. The NICE guidance covers headaches in over 12s, while the SIGN guidance is on pharmacological management of migraine. We have a module providing tips from both of these pieces of guidance. By the way, this module has some great reviews, with learners reporting that it's very well explained and informative.
Oh, well, that's good to hear. So what should GPs be aware of in this guidance?
So this guidance module focuses mainly on migraine prophylaxis rather than treatment, and there's quite a range of therapies that can be used. Both NICE and SIGN have propranolol as a first-line treatment, with topiramate also high up on the list.
There are some caveats around topiramate for people who could become pregnant, though, aren't there?
Yes, that's right. So GPs are urged to be very wary of prescribing topiramate or sodium valproate for this group. Didn't we touch upon this in our last episode? Or one of our previous episodes, Rihanna?
Yeah, exactly. We talked about this on our episode on pregnancy challenges, looking at prescribing in pregnancy. And I spoke to Chloe, who's the editor of MIMS, the drug reference guide, about the latest changes to rules around prescribing of topiramate and what GPs need to remember about the pregnancy prevention programme.
That's very useful. And what about newer treatments such as botulinum toxin and the CGRPs, which I understand are the calcitonin gene-related peptide monoclonal antibodies?
So according to SIGN, botulinum toxin A is recommended for chronic migraine where medication overuse has been addressed and 3 or more oral treatments have been tried. So 3 of the CGRPs, fremanezumab, galcanezumab, and eptinezumab, are recommended by SIGN for chronic and episodic migraine after a trial of 3 or more oral treatments. A 4th, erenumab, is recommended only for chronic migraine after a trial of 3 or more oral treatments.
So those would probably be prescribed in specialist care, but perhaps good to know the names in case you encounter patients who are on them. And talking of specialist care, this module provides a guide on when to refer. For example, if there's a worsening headache with fever, if there's recent head trauma, or there's sudden onset headache that reaches maximum intensity within 5 minutes. This last one is a thunderclap headache that could indicate a hemorrhage or other serious cause. And giant cell arteritis and acute narrow angle glaucoma are two of the serious conditions to look out for. And elsewhere in this guidance module, Dr. Singh discusses some of the uncertainties encountered in this area. Can you talk us through some of those, Sangeeta?
Yeah, for example, there are several recommendations around off-label use of medicines in the NICE guidelines. These include the use of oral or subcutaneous triptans in under 18s and the use of amitriptyline and riboflavin for prophylaxis. This also applies to the prophylaxis of menstrual-related migraine with frovatriptan and zolmitriptan.
But clearly there must be a good evidence base for their use if they're being recommended by NICE.
Yes, and there is a signpost in the module to a leaflet from Oxford University hospitals which can be given to patients to explain more about off-label use.
And finally, I think there's some discussion of alternative therapies and possible new therapies.
Yeah, it's quite interesting that NICE recommends acupuncture for both chronic tension type headache and for prophylaxis of migraine if both topiramate and propranolol are unsuitable or ineffective. And oxygen therapy, you might or might not be aware that a Cochrane review of oxygen therapy in 2015 found some evidence that hyperbaric oxygen therapy was effective for terminating acute migraines.
I think the mode of action they describe is that the oxygen has an anti-vasodilatory effect and thus prevents the migraine from progressing.
So that's handy if you happen to have a hyperbaric oxygen chamber in your surgery.
Yeah, probably unlikely to find one in most GP surgeries in the UK, although you never know. So do let us know if you have one. However, this section goes on to say that there is some evidence for use of oxygen at normal pressure for cluster headaches, and there's some guidance for GPs from the London Respiratory Network on this, again signposted in the module.
Fascinating. So hopefully with some of the newer treatments available, there are more options now for patients who suffer from the debilitating effects of migraine. What have we learned today? Here's a quick recap of some of the take-home points from our discussion on neurological symptoms and headache. Firstly, when thinking about blackouts, ensure you're aware of the differentiating features of epileptic seizures, syncope, and functional seizures. For example, it's rare for an epileptic seizure to have a gradual onset, but this is frequent in functional seizures and common in syncope. Ictal incontinence is frequent in epilepsy, but only occasional in syncope or functional seizures. Second, dizziness in itself is unlikely to indicate a serious neurological pathology, except when it's accompanied by a focal neurological deficit, altered gait, or deafness. Dizziness with vertigo, on the other hand, may have a cause such as BPPV, but it's important to exclude stroke as a possible diagnosis. Third, use the Socrates acronym when assessing facial pain, as this can help you to start determining the cause. As a reminder, this stands for site, onset, character, radiation, associated factors, timing, exacerbating or relieving factors, and severity score. And finally, don't forget there are lots of options for prophylaxis of migraine that you may not have tried, and these are recommended in the NICE and SIGN guidance. Some of these can be prescribed by GPs, some might only be available from specialists, such as botulinum toxin or the newer CGRPs. But remember that there are risks associated with the use of topiramate and sodium valproate in people who could become pregnant. So thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Next week, Dawn Liz Powell will interview Professor Carolyn Chew Graham, who's a GP and also Professor of General Practice Research at Keele University. And they'll be focusing on the very important issue of supporting people with severe mental illness in primary care. So do come back next week.